A warm welcome to everyone to this ERNICA Quality of Life webinar. My name is Dr. Wallis and I'm a clinical psychologist from the University of Bath, England. I'm also a patient representative for EAT and I will be moderating this webinar today. This webinar will be recorded and the recording will be made available on the ERNICA YouTube channel. For this reason, please keep your cameras and microphones off during the presentation. At the end of the presentation, there will be opportunities to ask questions, so please either write these on the chat or put your hand up at the end. In today's webinar, we will be exploring an important topic, a traumatic diagnosis and the early parent-child interaction in rare and chronic pediatric diseases. We have two speakers, Professor Julia Quitman and psychotherapist Aukje Aarts. Julia will start with her presentation and then both speakers will be available to answer any questions. Professor Quitman, you're welcome to start when you're ready. You are on mute.
Yes, now you should be able to hear me, right? Okay, so thank you so much. It's a pleasure to be here. It's a pleasure to see some of you. And I'm really happy to have the opportunity to talk to you today about this very special topic, because I think while the situation of families with children with chronic diseases, especially rare chronic diseases, has already changed due or thanks to major advances in medicine, I guess little is still known about how affected families cope with such a diagnosis, how this affects the parent-child relationship and the bonding patterns. I think it's very important to really have a close look how children develop socio-emotionally in the long term and what specific psychosocial needs those families have. Therefore, we really appreciate the opportunity to meet you today, at least digitally, and talk about this. But of course, yeah, let me introduce us first. So hold on now. I have to, yeah, it works. Okay, you want to go first, please?
You're on mute, Aukje.
Oh, I'm sorry. Yes, I was just saying I'm very honored to talk about this topic today, and I hope I can add by asking your questions and discussing how or how my experience is and how we're doing it in the hospital. And I'm a psychotherapist, and I'm specializing in child and adolescent care in the Radboud University Medical Center, and especially in Amalia Children's Hospital. And my work is especially with children and adolescents, as well as their families, and particularly those dealing with rare conditions, and in both inpatient and outpatient settings. And for me, the focus is on optimizing the quality of life and integrating this approach into the entire treatment process and the communication. So not alone working with the families directly, but also working with doctors, nurses, and the system around the family. So I hope I can add some interesting things for you later when the questions are starting.
Thank you. Move on. My name is Julia Quitman. I'm a professor for applied developmental psychology here in Hamburg, and I'm also head of quality of life research at the University Medical Center here in Hamburg. My research kind of focuses, of course, on quality of life and the psychosocial aspects of rare diseases and family-centered care. And for several years, I have kind of like dedicated my work to understand and also to improve the well-being of patients and their families, particularly in the context of rare diseases and pediatric care. And accordingly, I explore how rare diseases impact the child's development and the family dynamics. I'm kind of like aiming to develop patient-reported outcomes and patient-reported experience measure that capture the very unique experiences of those affected. Yeah, I guess so much about us, right? Should I start now? Okay. So next slide. Let's talk about parenthood. I think becoming a parent is such a big luck, but also such a big challenge itself. And parenthood actually starts quite early. Most of young people already have an idea. Later on, I will have a child, or I have 2 children, and the name of my child will be this, and the name of my child will be that. And when I have a child, I'm going to do this and that with my child. So starting a family is really part of many people's lives. And of course, it's also associated with so many great aspects, like happiness and the fulfillment of the partnership and the family. So, and this is really something most of the people dream of. And also, pregnancy is not always, but often desired. But pregnancy itself might already take a long time, and this is not really something we talk about. We talk about if we want to have children, if we don't want to have children, but we usually don't talk about if the most kind of like natural thing, and I'm trying to, I don't know if you see me, I'm trying to put it, it seems like the most natural thing, but that is often something that does not come just like that, just because we want it now. So this is one of the first challenges, and then once the child arrives, reality gets us. So we see that it's not as easy and happy and great as maybe films and commercial and the very small parts that we sometimes see, are all of it. But having a child, being a parent, is quite challenging. So as much as parents are happy about their children, and about becoming a parent, they also experience that starting a family goes along with so many challenges. And I had a mother who said, I would never give up my child, but this is not how I imagined it of being a mother. So that's the first reality check, right? And this is not it. We all know that becoming a parent goes along with lots of responsibility. And it's also, we also know that the attachment is a very, very important aspect here. And attachment is not attachment itself. It's kind of like builds up. And the most important thing is the capacity of the parents to see through the eyes of the child. There's a very big attachment researcher you all might know, which is Mary Ainsworth, and she said it's the capacity to see through the baby's eyes, through the child's eyes, to understand what the child needs. So it's the empathy that's kind of like the cognitive or mental capacity that goes first. You have to understand what your child needs, what your child wants, why your child acts that way, and then you need to be sensitive on the behavioral level. So that means you have to put yourself kind of like back and see, okay, your child needs that. And now I have to be responsive. Now I have to answer those needs, because like a very young child doesn't really understand if I say, okay, I just sat down, I'm so tired, I'll come to you later. No, it doesn't work with babies that way, right? So when they cry and they only have very, very few possibilities. So they cry and they say, I need you, mommy, I need you, daddy, please help me up. And then together you have to find out, okay, what's the matter now? Do you want something to eat? You want to be carried? You want to be loved? Are you bored? What the heck's going on? And the baby's not telling you. So you got to be very insightful and empathetic. And then you got to be very responsive. And if that happens, most of the times, you don't have to be perfect, then we get the attachment that we all know about, and that's so very important for the child development. But in the case of like of children with a special disease, with a special condition, with special needs, this concept of empathy and sensitivity must be broadened, because children with special needs might have special needs and it takes even more empathy, even more insightfulness, even more sensitivity, so that very, very fragile first relationships can grow. And therefore, we think it's very important to adapt to the child's diagnosis, to accept the child's diagnosis, and learn to cope with that. But this is a very, very challenging thing, and I'm all into challenges right now. I'm sorry about that. I told you about those different challenges and about the ambivalence of parents in the very beginning. And when parents get to learn that their child has a special condition, has special needs, I told you it's even more important to be empathetic, to be insightful, and to be sensitive. So this very fragile attachment and relationship can grow. But when parents learn that their child has a chronic condition, there are lots of feelings for lots of families that goes along or might go along with such a diagnosis. Sometimes parents ask themselves, what did I do wrong? And there's lots of course, there's first shock, and then there's guilt. Maybe I shouldn't have done this and that, or maybe you shouldn't have done this and that. And parents get to, get to argue. They feel helpless. They feel isolated because, especially with a rare disease, who knows about it? They they're very, very sorry for their child. They're very sorry for themselves. They're overloaded. What are they supposed to do? So all different feelings, and sometimes all different feelings at once, and all different, or like sometimes it's this feeling now and the next feeling at that time. And who do I approach with that? And the diagnosis process is very is very special, especially in rare diseases. Sometimes it takes a lot of time between the first suspicion and then the diagnosis. And the parents I talked to told me that the uncertainty is even worse than having a diagnosis. Even though with a rare condition, sometimes you do not know what will happen to the child, or if there's a treatment and which treatment is right. But then it has a name, and maybe sometimes it goes along with therapy and somebody knowing what to do. But in the beginning, lots of parents tell me that they have the feeling you'll never be happy again because you feel guilty or you feel isolated, as I just told you. And you have the feeling you'll never be happy again. So, because what's this supposed to mean for you and your child? And then, especially with the rare diseases, it's often very difficult to find somebody who knows what to do and who you can trust, because there's nothing more precious than your child, and who you're supposed to go to when you learn that your child has this very rare condition. So and sometimes you feel, even with specialists, you feel lost. So I have this example that parents told me, okay, to visualize this suspected diagnosis, the doctor copied me these pages from this dictionary, and it told me all these very, very, very terrible things. And then he left me alone with this. And what are you supposed to do? What does it mean for you and your child? So that's very critical too. So what does it mean to have a child with a rare and chronic condition? There's no standardized definition. So this is very difficult too. Chronic diseases, chronic conditions are long-lasting illnesses that cannot be completely cured and result most of the times in a persistent or recurring increase in the use of healthcare services. And to date, little is known about as I said in the beginning, about the psychosocial, psychological development of those chronically ill children in infancy in general, and children with rare diseases in particular, and the impact of the condition and its treatment on the parent-child relationship that develops is, as I said, very important for the child, for the families. So, and we know that sometimes chronically ill children, or not sometimes, but chronically ill children show a significantly higher risk of psychosocial difficulties, and they even tend to be more vulnerable for psychosocial difficulties and even illnesses. So therefore, it's very important to help from the very beginning, I think, and maybe to work on this little knowledge that is still there. Because I think, with the rare diseases, we always think it's just very few. How should we know about this? But if you just look at the rare diseases, a disease is rare if it affects no more than 5 to 10,000 people in the EU. But that means like 50% of people affected of rare diseases are children, and those children have parents, most of the times two parents, right? So that raises the number. And as you can see, approximately 7,000 rare diseases have been identified. And if you combine all this, it's 30 million people, and those 30 million people have families, and they suffer and they go through this together. So it's a lot of persons, people, families that are affected by rare diseases, even though they're not the patients themselves. And we know from studies that children with congenital, for example, with congenital heart defects and might have severe psychological problems. And it's not the heart only that is affected, but it's additional family issues which might be caused or might go along with those congenital issues. So we have to really see that, it's this first. I don't know if you can see me. I'm sorry. I'm trying to show you something. So it's this first pyramid I was showing you. It's the insightfulness, it's the sensitivity, and it's then the attachment in even more challenged surroundings that we have to look at. So we have to really not only take the patient itself as a patient, as a client, but we have to work with the whole family. And I've got a example for you. From a family with esophageal atresia. And this mother told me in a retrospective way about her problems. And she told me that her son was born without any problems. And she was really happy when she gave birth, but then he was taken away from her. And then the doctor didn't come back with the child. And at some point he came back, and she was already, kind of like insecure and wondering, where's my child, what's happening. And then he kind of like told her, listen, we tried to aspirate your child, and he spit it up, and the tube doesn't go down, and I don't know what's going on, and it won't go through, and your child might have this and that. And this woman told me, I had no idea what this is supposed to mean. And she was just functioning. She said, I want to see my child. I want to see him. I want to have him. I want to feel him. I want to be there for my child. And then the doctor just said, no, you have to decide which hospital he will be we will fly him to. There's the helicopter coming. You have to decide, is it this or that university hospital? And she had to functioning, and she was really, really challenged. And the most terrible thing for her was that they told her to decide, but she wasn't able to follow him. She wasn't allowed to go with him. See, she just gave birth. Just being a woman, just giving birth. I did it 4 times, and I can tell you, you're not in really the place to just hop in your car and okay, I'll follow you. I'll be fine. So she had to function, and she had to make really very, very crucial decisions, and that was definitely too much. And then she said the worst thing was when they arrived, they took the baby from her, and he was screaming, and she said she'll never forget that. He was taken away from her, and she had to kind of like see how she could follow him. So I think that what I'm trying to show you is that in many cases, the diagnosis is difficult for the clinicians because sometimes you just have to find out what's wrong with the child. And then, of course, you have to tell the mother, the father, the family that something is happening. Maybe you're not sure yourself what's happening, but you just have to find out what it is. And you have to admit, okay, there's something. We have to find out what it is. We'll do it together. Um, but as in this example, which I was trying to show you, the very, very first bonding, which we know is so important, after giving birth, having time together with your child, leaving the family by themselves, and protecting this very, very fragile relationship. You cannot be doing this because you need to secure the child's life, rescue the child's life. So, young parents are confronted with such a diagnosis, and there are studies from different clinicians and researchers that describe the psychological reactions of pregnant women and parents whose child was diagnosed with a fetal development disorder. And they said for these children, or for these parents, I'm sorry, it's exceptionally emotionally stressful, and this stress makes something with us. Stress makes us ill. This is a child with a rare condition. It's a parents which are very, very stressed, and it's a very vulnerable relationship. And the child's diagnosis therefore interrupts the very natural process of attachment, and these parents are very confronted, and sometimes they think about, well, do I want to get a relationship with my child if he or she is not going to be there for a longer time? What am I supposed to do? How can I manage? How can I take responsibility? How can I care for this child? And these parents need to be, okay, you're going to say something about that, but these parents need to be mothered and fathered in order to be able to be a mother and a father. So it is well known from child or infant and child psychosomatics that the psychological stress, the parental conflicts, the parental perceptions affect the child through the parent's behavior. And even in the long term, the child's development depends largely on the parent's psychological processing of this illness. And I think, well, I'm repeating myself. um, I'll go on. So affected parents go through various stages, and sometimes they move up quite fast, and sometimes it takes forever, and some parents will never fulfill phase one, and sometimes parents will be very fast in phase through. So they have to come to terms with the uncertainties about their ideas for the future as parents, for the future as a couple, for the future of their child. And many parents initially feel helpless. And I told you sometimes they feel guilty, and sometimes they think, what have I done wrong? If I wouldn't have eaten this and that, if I wouldn't have drank this and that, if I wouldn't, whatever, have make sports work out. I don't know, sometimes it's you have crazy ideas just to try to find a cause. So and sometimes, denial is often one of the first strategies in response to being told a diagnosis. Parents may ask themselves, why me? Why me? Why do children? I wanted this child so bad. There's so many families who don't even want their children. They don't treat them right. And I wanted this child for maybe sometimes a long time. Why does it happen to me? We wished for this child so long, so bad. And this mourning phase is an important phase. in the process or in the processing of the loss, and the realization that certain goals and ambitions, as I said earlier on, you have ideas when you're going to have your child, he's going to be this and that, I'm going to do this and that with him. So the realization of certain goals and ambitions in the child's life can perhaps no longer be achieved. And this can be perceived as a loss that triggers again grief. And goals and expectations must be adapted to the new situation, to the child itself, to them, to the parents themselves. And parents must learn to focus on what the child can do and not do, and what they should be able to do or could not do. So, so it's important to say goodbye to the ideal child or to the perfect child and accept the child that they have. And sometimes it really takes time. But hopefully, if the grieving process goes well, feelings of acceptance and hope increasingly find their way into everyday life. Despite occasional doubts, many parents manage to make the best of the situation. And when asked retrospectively, as I did, they reported that they were now kind of like overjoyed, and that the reorientation of their own priorities kind of like enriched their lives. But this sometimes take time. And they tell me, like most of the parents from a retrospective way, that they could enjoy the little things in everyday life, enjoy life with their child despite the additional burden. And yeah, sometimes they say, you know, like maybe 10 years later, I no longer have any problems with this. And the first step is to kind of like ask or stop asking yourself, why me? Why this? Why that? You just have to accept it. That's what parents, or that's what one parent told me. So according to the parents interviewed, the process from denial and anger and sadness and rage sometimes to the acceptance can take, well, weeks, months, and years. And over time, the parents integrate their child's condition as well as the additional, well, doctor's appointments and other oh, sorry. Well, I'm trying to say a word that I cannot pronounce. So, well, the special needs they have to adapt in everyday life. And an open approach to family, to friends, and later also sometimes, you know, kindergarten and school proved to be a constructive way for the participants and I was, or to the parents I was talking to. And sometimes they told me it was very difficult to start talking about it, especially with rare diseases, because no one knows what it means. But she told me when we first told them, we simply grew together. And today, it's no longer a big issue. So the reaction to diagnosis is very important, and processing the diagnosis is very important. And this is, as I said, a very fragile time where parents need reassurance, need help, not only once. Sometimes they tell me, yeah, if I would have known about this, it would have been also much easier. And then I talk to clinicians and they say, well, of course we offered help. But sometimes you get to learn about the diagnosis, and at the very end, the doctor tells you, okay, if you have any problems, we have this very special whatever institution where you can go to. Well, you have heard that, but you have to hear it once again and so many times, and maybe you need to be reminded, because it's if children well, if the parents get to adapt the diagnosis, they have more opportunities. So let me try to get to the point. Long story short, parents of chronically ill children are highly affected by dependencies of support in support systems. And I think the doctor-patient relationship is very important. And it's not enough to say once, if you need more help, tell me, or turn to this and that. You have to repeatedly maybe tell them and say, okay, I know I tell this every time, but as I see now, there are quite some challenges you're telling me about. Maybe you want to think about it again, that there's somebody who can help you. So to help them be empathetic, to help them to be sensitive, and to help them build a strong relationship and attachment. And I think it's very important that we all work together in a multi-professional setting for these families. We need to have a systematic approach for these families. Sometimes it's time that helps most. Parents explained that they needed time to absorb and reflect the news. As I said, sometimes they were told that there's help, but they might not be able to hear this because it's too much information they need to absorb. So they prefer to receive information together, like sometimes with a friend, sometimes with whoever support is there. And if necessary, it's sometimes good to bring a friend or bring somebody else from the family who is not as shocked, as like involved. So bring other family members or friends with them to support them at medical appointments. And they all families also told me that it was important to them that they were listened to. And sometimes they tell um, same things over and over again, not because they want to bother you, but just because it's very important to them, and they need to find answers for themselves. And sometimes it's just important to listen, and perhaps see that information which are communicated empathetically again, and honestly, and also at like the same eye level, or using simple language, so it can be understood. And the healthcare professionals should take enough time for this conversation, because otherwise you might lose them. So parents are often overwhelmed, as I said repeatedly now, I'm sorry, by the diagnosis, and only remember very few details, maybe only just the very rough details. And therefore it's important to make sure that they really understood and repeat the most important informations once or all over again. So parents need precise information about the child's condition and possible intervention, and not only the clinical interventions, but also the psychosocial interventions. So they need the opportunity to ask questions again and again, and also especially after the initial shock has passed. And therefore, it's important to offer parents a new appointment soon after the diagnosis has been communicated. And the healthcare professionals who communicate the diagnosis will perhaps often not carry on with the further treatment. So, but instead refer the families to special clinics, to therapists, and so on. So there's a good coordination needed. Get to the right help system to kind of like build the network, which is helpful to the parents. And also it's very helpful to see that they're not alone by themselves. So sometimes self-help organizations really help to see it's not only you. There might be others, and learn from others how they adapted. I'm almost done. So in concrete terms, they need psychosocial support. They need somebody they can turn to if they have, once again, questions. So they need just this, what you see there. It's not the parents only that need to be empathetic and insightful and need to respond on a sensitive way so that the attachment to their child grows. They need clinicians who are empathetic and insightful. They understand what the patients and the families need in this very special situation, and then they need to be sensitive on a behavioral level so that the patient doctor relationship can build, and we need this relationship for the attachment here for the babies. So the parents need to be parented somehow. So my conclusion for practice, based on the experiences of infant and child psychosomatics and parent-child psychotherapy, the specific parent-child interaction must be the focus of all efforts, or at least must be not disregarded in interventions with parents. And parents' coping strategies should primarily also be kind of like evaluated and supported from the point of view of kind of like how they function for their child, for themselves, and the parent-specific coping strategies and their effects on the partnerships and the relationship with the child should be observed, and not only now, but long lasting, and if necessary, it needs to be worked on. So I would hope that in specialist centers where infants and children are treated with rare conditions, we need staff not only trained on clinical issues, but on infant-child psychosomatics and early development. And of course, for research, we need somebody who focuses more on this, on the development of children diagnosed early, and then the families need of hopefully be followed, and we need to learn from the families what they need, and then help them. Yeah, and of course adapt to those fragile situations of the families concerned. That's it. I'm done.
Thank you very much for your very informative presentation, Julia. I'm sure we all found that really interesting and very important to consider the attachment and the early relationship. Now I'm going to invite Aukia to talk about her clinical experience and in relation to your talk, Julia. How was listening to that presentation? How was it for you, Aukia? And I'm sure there were many links you could draw to your clinical work.
Yeah, indeed, that is. It's for me, it's very inspiring, but also very recognizable. For me, one of the most important things, and one thing that I think it has been a very big help in our hospital, is that we, as a psychologist, I make acquaintance with parents right after birth, and then I can tell them I'm a psychologist, I'm part of the team, and it's not, and that's normal. So it makes it easier, or at least a little bit more normal for them to ask for the psychologist. But then after 3 months, we will introduce ourselves again, because most of the time when the child's born, Julia says there's a lot of information, a lot of feelings, a lot of important issues which need to be addressed first, and then after 3 months, when everything is settled down, then there's more room to talk about this. And then the most important thing, and I would love for everyone to, I think everyone can tell this to parents, and I can, every time I do this, it's so helpful, and also the nurse and our doctors do this, and it's helpful. I'm very impressed about when you're getting, and what Julia told, when you're becoming a parent, there's one thing which is very important. You have to keep your child safe, and you have to keep your child comfortable, psychologically, but also physical. And what these parents need to do, and especially the mothers, it's very, very difficult, is that in order to keep your child safe, you have to accept, or even say it's okay to acknowledge that the doctor has to make your child uncomfortable. And that is very hard. So when the mother has given the baby for the operation, literally give in, and they also tell me, I gave it away, I gave it to the doctor, and then it came back and it had all these tubes and all these things. I needed to keep it safe and comfortable, but it wasn't comfortable. And if you can address this dilemma, I see it's very how do you say, healthy, or I don't know the word in English, but it's very helpful for the mother to be acknowledged in this difficult dilemma, and to give words to it and to be understood. And that's all they need. It looks little, but it's very hard. It's very helpful. And also if the doctors say this, because now they say, oh, I will operate on your child and I'll keep it safe. But that's not safe in a mother's experience. So that's one thing which is very important, I think, to realize. And then another thing which is very important is that, and Julia, I realized it during your talk, there's a lot of emotions and difficult stages which parents have to go through, and they need to be parented at that. And the big issue with it is that we think fast, and also because we're worried that it's not normal, or that it's non-adaptive behavior, or that it needs special care. And most of the time, and parents can feel the same thing. I'm not normal. It's not normal to feel this insecure, or to feel that I don't want this child to be, or this is not how I imagined it. And then explaining to parents, but also to the people who work with the parents and the children, that it's normal behavior in an abnormal situation is very helpful. I see all the time it's giving relief. And it doesn't mean you don't have to attend it or address it or not talk about it, but it's not, how do you say, non-adaptive. It's normal behavior in an abnormal situation, and we have to decide when more help is needed. But that's another important thing, I think, to notice, that when parents are in the hospital and they feel all these things, or this attachment is not going well, or they're in this insecure state, we need to parent them, and we need to see it as a normal reaction in an abnormal situation. And then we have to talk about it and address when it's going over this border. But most of the time, if you give it time, and you give it, you give the parents the trust and knowledge, or how do you say, handvat? You give them material to handle it, they will be secure, and they will tackle all these difficult things they have to go through. And one of the other things which I see, I do a lot of treatment, and so we treat the systems, but also sometimes the child, and then it's very important to make the whole story. And I see, but that's just clinical experience, but I see a lot of parents where the story begins after birth. But when you talk with the child was in her mom's belly already. And to talk about that and the safety, the child was in there, I also see that's very helping to come to terms with something. So there's also a safe space, and that's always there. And to refer to that, and with the child, and to make a story, if you make a story about how it was born and how it came to where it is when I see the child, but always start before giving birth, but and when it was in the belly, and have the translation that it wasn't just all these worries, but there was also a lot of love. And then the last thing we work with is if Julia, if you say nurses and even doctors, they need to parent the parents, they need to, also I think we as psychologists and social workers sometimes need to not to parent, but to comfort or to strengthen the nurses or the doctors, because it's a very difficult thing to do, and it's difficult to decide, is this normal, is it abnormal, what does this mother need? Or when a mother says something, or a father which is maybe despair, and you think, well, we do everything and now you're getting mad at me, or you don't, or you dislike something about your child. So we need to translate this language into, okay, what's said and what's meant, or what is the intention about what's said. So I think that are that's the focus of my work. Yeah. I don't know if there are questions or maybe.
That's great. Thank you very much. And I think that normalizing the difficult emotions is so important. And as you say, to provide the parents the words to describe their reactions to difficult and abnormal situations. And I loved when you said that, talked about the story and how it began before the diagnosis, to almost like to remind the whole family unit that the love was there before, and then that almost like brings it back to the hope that Julia talks about, that you can return to those feelings once this difficult adjustment is going, and then really important to support the medical teams throughout the process. So that was great. Julia, have you got anything to add to that, or shall we give the floor to the audience to ask some questions?
Yeah, I think I talked enough. Let's open the floor.
Yes. So please raise your hand if you would like to ask a question, or then you can also write it down, whichever would be more convenient for you.
I see that we received 2 questions in the Q&A.
Okay, yes.
One question is, how can clinicians ensure that fathers are supported as well as mothers? And what should we offer grandparents as advice to accept and empathize with parents?
Yeah, I think the first question about the fathers is very, very important. And I think it's important to talk to the parents together, but also to talk to them differently or besides each other, because in my opinion, they want to protect each other. So maybe they won't tell everything, or they won't tell everything. And I think it's a bit of you have to be directive. So I think you should address the problems and ask the father, or say to the father, oh, it's important for you to be there. So do not accept if he's not there, if he's only there to talk about the problems or the medical issues. You have to address it. And like Julia said, I think it takes time, and repeat and explain why it's important that he's there, because it can only go so well with his child and his wife or the mother as it goes with him. And well, in my experience, if you're sincere and you take the time, but you address it every time, then they will come there. And again, explain that it's normal in an abnormal situation. I think that's one of the key things to explain. And not take no for an answer. Take no for an answer. Respect the I don't know if I say it right, but the boundaries, or the accept what father says, but it doesn't mean you cannot address it the next time and the next time you see them. So just keep on asking them. I think that's what I would say. I don't know, Julia, if you have anything to add to that.
I think I talked about a network, and the network, of course, is first the family, and whoever's there, if it's mothers and fathers or whatever, we need to combine support the whole family. And I think it's very important to see the different, and they have different, from my point of view, and as you said, they have different experience different challenges, and they have different resources, and sometimes one functions better at this time and one functions better at that time, but and they have different worries and different strengths. So and you need to get the whole picture, and we haven't talked about that yet, but I want to say they're also the siblings, and sometimes they're siblings because parents get told you cannot be there forever, but your child needs forever help. So make sure your child gets siblings. So these children get born in order to support forever their siblings, their ill or challenged siblings. And so, sometimes they're siblings who have been there, and then there comes a new child, which is a challenge again, and then this child takes all the attention because it's ill and it has something, and it's a difficult situation. So you need to always see who's there, because whoever is there can be a network and can be a strength and can be a resource, and sometimes they need something in order to be a resource. And so I think it's, as you said, it's very important to see who's there and who needs what, and to make sure everyone gets whatever she needs.
Thank
And that
you.
maybe also,
Yeah, sorry, carry on.
now, I think that's part of the answer on the other question, because grandmothers and grandfathers, they have double, how do you say, so they have double problems, because they're worried about their grandchild, but they're also worried about their child, or hurting about their child and their grandchild. So I think it's very important, if you're looking at the family, to take them in, because they're also, I think, very much a protective factor, because they will stand in when the mom needs to rest, or when it's just not going well, or so it's very important to look at them too. But I don't know what the question was especially.
Yes, it was what kind of advice should we offer grandparents to accept and empathize with parents? I guess one of the difficulties is that each family unit is very unique before the child's diagnosis as well, and there can be different complications as well. So I think what you were talking about, sort of getting to know each family unit and seeing what their needs would be is really, really important. There's another question which is really important when thinking about rare conditions, that how would you help a family whose child has diagnosis of life-limiting health condition? Who would like to go first on this important question?
Well, I kind of like I just touched it very shortly, and as I said, sometimes for families it's very difficult how to bond with the child who will not be there for a longer time, even especially when this time is very limited. So and time's not there. Okay, you just said it, and I also said it takes time, but what to do if time's not really there? So that makes it even more difficult. And it's so easy to say, enjoy the time you have, make the most of it. How can you try to, or how can you be allowed to, or allow yourself to love a child when this love is not going to last? So I think that's a very, very special or very vulnerable situation. And well, I think from my experience, the most important thing is not to, how do you say, it's not on us I'm I'm lost in words. Anybody German here? No. Not to say, oh, you're going to be a bad parent if you're going to regret it if you don't make the most of the time. It's not on us to rate and to say this is good and this is bad, but it's rather be there and see what the mother, the father, the grandparents, whoever is there needs. And yeah. Okay,
Yeah.
please step in.
Yeah,
I'm
I
lost in
think
words.
that I can only I think that's the case. And in Holland, I don't know if it's in Germany or any, but we have it's called kinder comfort teams, child comfort teams, and they well, there are a lot of so there are nurses, doctors, spiritual caregivers, psychologists, social workers, ethical. So and they will provide the care, and we'll talk about it, and then we'll in each family we decide, okay, who gets in or who can add the help. There's always this nurse who and they also do this advanced care planning conversations, and I think that can be very helpful, but you have to timing is everything, because it needs to be at the right moment. And also sometimes parents want to talk about advanced care planning and think about, okay, when it comes to saying, it comes to the end, but sometimes parents are not so we are ready as doctors or as nurses to talk about this child, how do you say it, going to die or decease. But the parents aren't yet, and I think it's very important to follow the tempo or the time of the parents. But I think the kinder comfort teams and that advanced care planning is a very very beautiful thing that is available.
Yes, I think in this this area that there might be quite a lot of differences between different countries on what is available. In the UK, similarly, there are children's hospices and some specialist charities who do amazing work supporting the whole family in their shorter but very special journeys in life. So thank you very much for the questions, and thank you very much for our speakers